A small study that was done by one of the registrars in our service about 18 months ago in P Block at Monash Medical Centre showed that the only variable, when you controlled for all the other variables within the study, that actually improved readmission rates was a family meeting prior to discharge. The acute treatment plan, as also the continuous treatment plan, includes specific identification of a carer, the identifier of specific carer issues, and an agreement and guidelines with the carer about what they should do in the event of a deterioration of the consumer's condition. At the bottom of the acute treatment plan, the clinician needs to state if they have discussed the plan with the carer, and if not, actually indicate why not. This component of the care plan seeks to enforce the clinician to think about how they have engaged with the family. Following the completion of this plan, the consumer then signs the plan to indicate that this has been discussed with them and that they have received a copy. A further point I would like to raise is that many clinicians have been trained in a psychotherapeutic model where confidentiality of the clinician-patient relationship is paramount and felt to lead to significant trust with the clinician. Now, this is one of the things that families find very difficult, that clinicians will hide behind that confidentiality of the doctor-patient relationship. However, many clinicians do not wish to break that patient confidentiality, as they truly do believe that it's fundamental to the clinical care of the individual and have a poor understanding about the legal issues surrounding that confidentiality. In the past 20 years, confidentiality issues no longer are a confusing problem for most clinicians if they believe there is reasonable threat of harm to self or others.
There's no doubt that you can't complete assessment to reach a diagnosis without knowing the person. And knowing a person requires knowing everything about the person. And there's no one know a person better than the family who brought up that person and reads the person. So the family are a source or an asset to help to understand the person and to help to reach a diagnosis. There is also the assets the person have with coping strategy, and one can reach to that by knowing the person very well and knowing the family very well. In managing a person, the assets is there to be able to manage the clients or consumers because they are living at home. And as I stated that when we deinstitutionalized psychiatry, all our consumers are living at home, living in the community. Very few are living in institutions anymore. So being at home means that somebody is looking after them. So who provides the care? It's the family. So it is important to have the shift really. And shift during diagnosis, consult the family during treatment, and when we discharge people, they live at home and they have the rest of their life to carry on with the life, and obviously the family are an important asset, or the carer important asset at that time. Training for talking to families, yes, we engaged following the idea of producing the Chief Psychiatrist guidelines. The Chief Psychiatrist's office, together with Bovary Clinic, went around the state in a training program how we talk to families with special examples about how we engage families. It is important that we maintain that confidentiality is an important cornerstone of our work. If somebody comes to talk to a clinician, that is a confidential material. However, confidentiality doesn't prevent us from providing that person with the best outcome. And if we know that what we are doing is not helping in providing the best outcome, then I think we need to tell the patient, or the consumer, in order to be able to provide you the best outcome, I need to talk to somebody in the family. And I gave several examples when I had St. Vincent, that a young person told me that, or told the staff, repeatedly, I don't want to talk to anyone of my family, but every second day take an overdose and brought to casualty, say it was an impulsive, they send him back to home. Who was at home? his mother, he calls his mother, lives on his own, he calls his mother to come and see what's happened to him. And that happened for about 2 weeks. When I was reviewing the problem, I said, well, let me talk to him. And I said, well, I have to talk to your mother. I said, no, you can't talk to my mother. And I said, why not? I said, well, I ban you from talking to your mother. But I said, you go to her every time after an overdose and ask her to come and help you. So why are you doing that? And I will not be able to provide you with adequate help. There is an illness which is obviously not managed properly because you repeatedly do that every 2 days for the last 2 weeks. So I'll have to talk to your mother, admit you to hospital, and what I did is talk to his mother in front of him and talk about the issues and the problems. So the confidential material he doesn't want to disclose is kept confidential, but it's about the whole issue is why is he doing that and how that can be managed. And I will tell you, the experience normally that the person himself following a treatment, thank you for what you did, because you actually managed to offer a much better help and resolution in the relationship, and things move on in their life. And I can repeatedly say another client, a young lady who said, don't talk to any of my family, and I said, well, I need one person to talk to. Never my mother. I said, fine, I'll talk to your father. I said, no, not my father. I said, I'll talk to your sister. Not my sister, I'll talk to your brother. And she said at the end, if you insist, then talk to my mother. So I went back and brought the mother to the session and talked to her. I think that it is sad that clinicians are brought up in a culture that not to involve families. If my son or my daughter suffer from cancer, and they don't, and they are active pharmacists, both of them, but any of them suffer from cancer, I would like to know what's happened to them. And it's natural. They would like me to know, and we share together that sort of experience of how we deal with it. I can't understand why don't we do the same in mental health. I just cannot understand. If my son or my daughter develop an illness, it will be natural in our relationship that they will feel comfortable if I'm involved in that management of that illness, because they become desperate at that time. And the illness is so cruel, and the illness is so bad illness, is as bad as cancer, but it's treatable. And not to involve families is really, I know that sad thing that the understanding of the law of confidentiality took people to the other extent. And the last thing I want to say that as a chief psychiatrist, most of the complaint we receive is about families are not involved. And if families get involved from the beginning or during the session or afterwards, there will be a far better standards of care and a much less complaints. If we want to improve efficiency in our service, I would say that if people talk to the family from the beginning, we'll save a lot of time wasted after that in understanding what needed to be done. Thank you.